Welcome back to the Pharmacist Diaries podcast. This episode is part of a series I'm doing for World Antimicrobial Resistance Awareness Week. This is a global campaign that highlights one of the most urgent health challenges of our time, antimicrobial resistance. You might have heard of the term superbugs or maybe read headlines about antibiotic-resistant infections, but behind these terms are real people, real stories, and real healthcare workers on the front lines of this crisis. My hope is that these conversations will serve as a reminder that antimicrobial resistance is not a future threat. It is literally happening right now, affecting real people and requiring all of us to play our part in preserving these life-saving medicines for future generations. Today we will hear from my special guest, Rachel Berry. Rachel is one of the Chief Pharmaceutical Officer's Clinical Fellows, currently working at the UK Health Security Agency. That's a lot of words actually to get out there, but I'm going to roll with it. She's been qualified as a pharmacist for a number of years, mainly within hospitals, but her most recent role has been as a medicines optimization pharmacist in a large CCG and now part of a larger ICB. Her passion for antimicrobial stewardship spans across multiple roles she's had as a pharmacist, starting from a cystic fibrosis and respiratory pharmacist, becoming an antimicrobial pharmacist, an independent prescriber, and most recently, a lead pharmacist for AMS within her primary care medicines optimization team. However, she's also had some personal experiences within her own family journey, and these have really helped her to understand the impact of antimicrobial stewardship and the need to continue working within this specialist area. Her current role as a Chief Pharmaceutical Officer's Fellow at the UK HSA has given her even more insight into the world of AMS, but at a national level, working jointly with various organisations both nationally and internationally. Let's dive into this week's episode. Hi, Rachel.
Hi, Anisha. Thanks for having me. I realised I have some very long titles and you should try spelling them on a regular basis too.
I know, but even when I try to get them out, it's like really difficult. UK HSA really gets me every single time because I've had to use it as a term on the podcast before and I always fumble with my words. And even the Chief Pharmaceutical Officer's Fellow always gets me when it just makes me spin. I don't know why, but it is what it is.
Yeah, I can't spell pharmaceutical and I really struggle with pharmacist. I've got it as an autocorrect on my word because I always end up putting the M before the R and all sorts.
Well, it's so good to have you on the podcast. Thank you again for making time for me. That's number one. A really important thing
Thank you
to
for having
say.
me.
Yeah, absolutely. And I am really excited to just get to know you, learn more about your passions as well. So let's start today's episode finding out why you became a pharmacist in the first place.
So I became a pharmacist in the first place because I went to a grammar school and I was expected to go to university and my teachers wanted me to do medicine, which I think is a really common theme with quite a lot of pharmacists. I don't really like the icky bit of people. So the idea of doing medicine and having to be hands-on with patients really put me off. And I was looking at alternatives to that would use my sort of science background. I'd done GCSE history, a year-long course around the history of medicine and found it really interesting. I loved chemistry. And weirdly, my dad was an aromatherapist and had been training to on how essential oils can impact on how the body works. And it just fascinated me and it kind of came from there, really.
Awesome. And quite a few people also say that they considered sort of medicine as an option, but when they realized the need to obviously physically assess patients, you're going to have to touch patients, you're going to have to see potentially blood, pus, other things that just freak them out, that they've ended up going for pharmacy as an alternative option. So you're not the only one. There's plenty of us out there who've kind of considered that as well.
I think so, which is it's a bit I guess it's a bit crazy because I am an independent prescriber now, and I obviously have done hands-on assessment of patients. Just feel at the time I wasn't ready for it, and I wasn't really ready for the hours and the high level of academia that was required either. So this was definitely a good fit for me, and I'm really glad I chose it.
Cool. So tell us a little bit about once you qualified as a pharmacist, or maybe actually when you were in university, what were your initial thoughts as to what pharmacy was going to look like for you and then how things molded?
So I was lucky enough to study at Nottingham, and we did a lot of joint training with the medics, which was great and really gave you quite a good clinical um, grounding, I guess. But I qualified 20 years ago. Clinical pharmacy wasn't really where it is now. It did look a little bit different. We were working on the wards, but where I did my pre-reg, showing my age, where I did my pre-reg, we didn't have any prescribers at the time. It wasn't really pharmacists weren't delving out into prescribing. I did my pre-reg at Sheffield Teaching Hospitals, and then I went on to do a residency there as well, which was brilliant experience. And the training they gave you was really widespread. You covered loads of different specialities, loads of general wards, and the residency gave you really good experience with loan working and clinical decision making. We were in charge of the hospital pharmacy department overnight, having to do aseptics, making up aseptics on your own, and just really good experience of sort of getting out there and just being a pharmacist and not having to, just stop going out and doing it, and being supported by your team to be a professional right from day one. As soon as we trained, so yeah.
And was your residency 3 years long? That's how long mine was back in 2010. But obviously, a lot of things are changing and evolving. And now, even though some residency programs are longer, you're finding that a lot of junior pharmacists step out of the residency and go into a Band 7 position quite early. So what was your experience like for residency back then?
So we did a 3-year fixed contract. You did the first year as a non-resident, just kind of getting your feet under the table really, and getting used to being a pharmacist, because you did need all that experience. You know, if you're going in and making IV chemo by yourself, you need to know how the aseptics unit works. So you needed to have that year's experience without being a resident straight away. And then we did 2 years residency at the same time as a diploma, our clinical diploma. And it was great. I mean, there were 18 of us across Sheffield Teaching Hospitals. So really good social life, in addition to really good clinical experience. We all lived in flats together, flats of 3. So you had that supportive network of other pharmacists in a similar stage to you, to be able to really learn from each other. But then the senior pharmacists really supported you as well, and you were there to train to be and to get to your diploma so that you could move into your Band 7 post from there. But it was a fixed term contract, so you could use that as a springboard to do something completely different and move away, which is what I did. We had people that went into primary care straight from the residency, or you could stay at Sheffield and apply for the next band up. So yeah, I mean, it was brilliant. I absolutely loved it, and it was definitely the making of me. I feel like things have changed. People are doing more shift work now, aren't they? And I just don't feel like as a junior you get that experience, although I can see why it's more beneficial for the department to run in that way, because from a risk management perspective, maybe having newly qualified pharmacists in charge of the pharmacy department wasn't always the best way to go. I don't know.
Yeah, I say quite a similar thing, that residency kind of created the foundation for my career. And of course, it was the beginning of my career, but it just gave me a really good baseline. A baseline in terms of my clinical knowledge, the skills that you need to be a great pharmacist, especially if you're staying in a hospital setting and you're very clinically focused and patient facing. And it just allowed me to gain a lot more confidence in a lot of areas, whether it's, like you said, the lone working, becoming more assertive, and the ability to say no. Because when you run a 24-hour service and you are the Band 6 who makes that decision as to whether or not you supply something or do a TTO overnight, or, you know, whatever comes up, or an emergency happens where you have to come in and supply certain medications, I built a lot of confidence over that time, which really helped me to make good decisions for the future as well. And like you said, social life was incredible. I had so much fun with the other residents. I did mine in Oxford, and we spent a lot of time with F1s and the SHOs. A lot of the junior doctors rotated to similar ward areas, so you'd have a lot of fun meeting each other on different specialist areas depending on where you were. So I built a really nice network, and I just loved the whole opportunity and what it gave me as an individual, as a professional. And it was just a great way to kind of kickstart my journey into pharmacy. And I loved it. I would do it all over again because I loved it so much. With children now, a little bit more difficult doing shift work. But
Yeah,
yeah, I did love it. I did love it at the time. And I'm so
I
glad that
absolutely
I
did.
did it. Yeah, I'm
I
so
did.
glad
I
to
mean,
hear that.
I met my husband at Sheffield. We did our pre-reg together, and we're both residents at the same time. And I'm still friends with a lot of the people that I trained with, and we bump into each other all the time. I do think that things are almost better, or to have more opportunities for people who maybe aren't in the same stage of life as I was. As you say, it would have been very difficult to have done it with children, and it was a full-time post. There was no options for part-time. So I feel like it's a bit restrictive on that sort of equality and diversity aspect, that it completely ruled out certain types of people from applying. But I think if you did do it and you, I think it was kind of a sink or swim kind of job. If you succeeded in it and you achieved and you fitted with the way that worked, it was really beneficial. But yeah, totally. I absolutely loved it. I wouldn't have changed it for the world.
Awesome. So let's fast forward a little bit when you started your cystic fibrosis and respiratory role. And how does this link into your love for antimicrobial stewardship, for infectious diseases, and learning more about antimicrobial resistance? Because obviously that's a ward area where I know a lot of patients will come in to be treated for IV infections, IV antibiotics, sorry, and they would be on long courses as well and have most likely quite drug resistant infections as well. So maybe dive into a little bit of your experience from that time and what you loved about it.
Yeah, so my job as a cystic fibrosis pharmacist was a big change actually from the band 6 and 7 posts that I'd had. It was the first ward that I worked on that I had regular patient. So we had a caseload. It was always the same patients. So you'd see them time and time again, the same patients. And that really gave me a lot of experience in patient communication and being able to have conversations and really make sure that patients knew what they were doing with their medicines. I'm not sure I ever really had that focus. I'd like to think I did when I was doing my more junior roles, but having then really got into contact with patients and realizing that they didn't have a clue what I'd said to them last time they were in, but I thought we changed this medicine last time you were in. Oh yeah, no, I forgot. I've not been taking it like that. And you suddenly realize that there's this whole additional aspect to patient life, which includes the wider NDT, it includes their GP, it includes their family and their carers, it includes dietitians and physios, and this whole wider aspect of hospital life and care of a patient that I don't think I'd fully understood at all. And what it did really highlight to me is the importance of antimicrobial stewardship and the impact that resistant infections had on my patients' lives. We had to do separate clinics for patients who had resistant bacteria and those who didn't, because you didn't want them to catch the resistant bacteria from each other. But then we realized that a lot of these patients go to the same social events because the Cystic Fibrosis Trust had local networks, and they'd be at each other's birthday parties. So we're desperately trying to keep them separate, but they're mingling socially anyway. So trying to work with patients and consultants and GPs and families and social workers and all of these different aspects to keep the patient safe was really, really eye-opening, actually, and totally different to anything else I'd ever done. And it is so important. We did have quite young patients who were on desensitization regimes for meropenem, our last line agent, and they were allergic to it, but it was the only thing we had to treat them because they were resistant to everything else. every time they came in, we had to start low and increase it up to try and make sure they didn't have a reaction. And this constant fear that at one point they were going to react so badly to it, we couldn't treat them. And then where are we? What can we do with these patients? It's an interesting job to be a part of, but I would recommend it definitely. Working with a group of patients on a long-term basis, same patients, is really rewarding.
I talk about this quite a lot on the podcast because when I share information, obviously, about my personal journey, I talk a lot about the details as to why I do the things that I do or why I enjoy them. And in the past, I've had conversations about acute versus chronic conditions and why I prefer working with patients who have chronic conditions. It allows me to build relationships with them. It allows me to feel like I'm having an impact on that patient long term rather than just seeing them for that kind of snapshot acute admission and then potentially never seeing them again if I don't have like a clinic that they can come to, or they're not, you know, repeat admissions for that patient. It's difficult to see what's going to happen to them. So I did a rotation in cystic fibrosis in Oxford and I absolutely loved it. And part of that whole kind of like multidisciplinary team was what helped me to realize how much I like working with other healthcare professionals. And now working in pediatrics and most recently in palliative care, I've really enjoyed, again, working in an MDT setting with nurses and with consultants and figuring out also the logistics or the complexities of communication between hospital and home or, with the GP. And it can get really complicated with CF because there are so many healthcare professionals involved. There is so much communication. There can be a lot of change to patients' regimes, lots of additions, amendments to what they're taking. And I can understand from their perspective how confusing it can be when it comes to adherence. I also remember, now that you've reminded me, is that we had patients on the wards, quite young, sort of teenagers, but they find each other, right, through social media. They find other cystic fibrosis patients because they have that connection with them. They understand what they're going through. And there were couples. There were, boyfriends and girlfriends dating, and they might even be on the ward at the same time. And you have to work really hard to keep them separated. And there was so much complexity that came with that in terms of patient care, which I hadn't ever experienced before working on that type of ward.
Yeah, I think with it being genetic as well, and it does run in families, we had family members or parents who had a resistance to bacteria that they were colonized with, and their kids didn't. And just how you just can't manage for that, can you? Really, like it just doesn't happen. But I just found it so rewarding. And as I said, I think one of the issues around band 6, maybe a band 7 training, pre-reg training, is that you don't see the breadth of the health service in its widest form. You just don't see it. As you say, you're quite reactive to one patient every time you see a drug chart or a computer system now. It was paper charts when I was there. But it just opened my eyes to all these different roles that people had to look after a patient. And, we had art psychologists and all these various roles and people who were involved, and primary care, as you say, their GPs and some of the nurses that we worked with really closely. And all of the additional needs, like you can understand why cystic fibrosis adults still panicked about injections because they've had them so often. And yes, they've got their port, but you're using the EMLA to try and make it easier for them. And you really trying to fit the healthcare system around patient much more rather than just assuming that they'll fit in to the healthcare system. And I think that's something that maybe the whole system needs to learn a lot more about, trying to make it a bit more patient focused.
Yeah, completely. I mean, it's definitely a challenging specialist area to be in, but I think a pharmacist has incredible impact in terms of patient care. And also, our voice is really valuable because there are lots of things that we know about medications, about antibiotics, about resistance patterns, and the need to start, stop, antibiotics, change from IV to orals, all of the things that we do in terms of stewardship that are so valuable in that specific type of area. Can you tell us a little bit about a specific patient journey? I believe that you had a patient that had a catheter-associated UTI that made quite an impact on you. Can you share that story with us?
Yeah, so this was actually a bit later in my career. After I left my cystic fibrosis job, I moved. My husband got a job at university as a lecturer, so we moved, and I got a job as an antimicrobial stewardship in a district general, and general role of reviewing patients with difficult infections across any ward. And one of the patients we had a catheter-associated UTI. She had been on holiday in Spain and was admitted to hospital in Spain for, I think, a fall, broken leg, something relatively minor, if I'm honest. Picked up a really resistant bacteria in her catheter and got on well from it and ended up in our hospital. And it was resistant to everything. We just couldn't treat it. And she ended up on a really toxic combination of IV antibiotics, clindamycin and gentamicin, and this constant battle between her renal function and the neurotoxic side effects and the trying to treat the infection, which unfortunately we lost. The lady did sadly pass away because she had a resistant infection that we just couldn't get on top of and we couldn't treat with any options that were available to us. And I think that really hit it home to me. You know, I'd been working with cystic fibrosis patients and working as an antimicrobial pharmacist for the best part of 10 years. And it wasn't until that moment that I went, oh, actually, this isn't something that is just a risk in the future. This is happening now. People are dying of resistant infections now. And not even because from something that was really weird and wonderful illness either. This was a catheter-associated infection. It wasn't, I would have expected to have been able to treat that, and we couldn't. And she was a lady in her 50s. She wasn't elderly. She didn't have any other comorbidities other than the fact that she did need a long-term catheter. And yeah, really impacted on me. Really, it changed the way that I looked at things quite a lot.
That is quite scary, actually, now that you've shared the story. And I mean, I've seen patients like that in my own journey, but sometimes when you hear it from someone else, it can also just make you think twice every time that you actually get a prescription from antibiotics for yourself or your family members. I was reading on the World Health Organization website last week about antimicrobial resistance, and I was looking for some statistics to share. And around just under, I think, a million people die each year from a drug-resistant infection. And the statistics in terms of the trends show that if we're not doing anything about it, or if we don't really have a strategy in place to improve the situation, by 2050, there'll be 10 million people dying every single year from these types of infections. And those numbers are super scary. They are really alarming. And obviously, the point of this series is to help raise more awareness of what's actually happening and to, like I said in the beginning, is to give us hope that people will watch these episodes and actually think twice about whether they take an antibiotic, if they're a healthcare professional, what they're doing when they're actually prescribing it, what does stewardship actually mean, switching from IVs to orals, things like that, and trying to look at sensitivities and choosing the right antibiotics for the right conditions. And it's even given me some insight as part of my current role. I'm working in adult infectious diseases, the impact that pharmacists have. And it's really helping me to kind of see the bigger picture as well on a global scale. But it's really quite powerful to share stories like this. So thank you very much for giving us a good example. I believe that you also have a personal story with regards to your family members who have been poorly and you've needed to actually think about antibiotic usage and how it supports, infections and how we can save lives by having antibiotic treatment. Would you mind sharing something about that as well?
Yeah, no, not at all. I talk about this often. It is the reason that I'm really passionate about antimicrobial stewardship and making sure that antibiotics really do keep working. So after it was only a few months after that particular patient passed away, my youngest son, who was 2.5 at the time, was diagnosed with leukemia. Really, really horrible time for the family. We had a 5-year-old and Will and Tom. So really difficult, and it's every parent's worst nightmare, isn't it, to have a child with cancer? And it really made me, again, really brought home the fact that actually we need antibiotics to be working. Every time Tom got a fever, we had to take him an hour's drive to our specialist treatment unit in order for him to have IV antibiotics and to have blood tests to check he wasn't neutropenic. And a couple of occasions he was neutropenic and had to be admitted for IVs in case he ended up with a life-threatening infection or had a life-threatening infection. And there is a risk of knowing too much, isn't there, as a pharmacist, when you've got a family member who's poorly. I was in total panic that he'd have a resistant infection one time and that we wouldn't be able to treat him. Leukemia these days is actually quite treatable, 90% success rate with the treatment if you get leukemia in under 5. But the risk was that he would get an infection or a complication that was the thing that was going to be a problem for us. So that really brought it home. And I was thinking about it, and this the statistics that you mentioned, that 10 million deaths from AMR globally by 2050. In 2050, my children will be my age. It's actually not that long away. And it really worried me because I don't want to live in a world where leukemia is something that people die of in the first 2 weeks like they used to 50 years ago. And I also, when I thought about it, my husband had an appendectomy when he was a toddler, had sepsis related to that and needed IV antibiotics. And my eldest son was born by cesarean section because we have placenta previa. So massive impact. Antibiotics are needed for C-sections. In that case, it counts as dirty surgery. So the risk for my entire family if antibiotics don't work would be massive. And yeah, a world where children with leukemia die, or my first grandchild can't be born by cesarean section if it needs to be, that isn't a world I want to live in. So that kind of really made me even more passionate. It was my job before, but now it's like my life, it's my passion, it's my family's lives. It's everything that we do. We need these to work. And yeah, so I kind of got a bit, I from there, I really kind of took those messages and I started the job working for the CCG and now the ICB, and I still lead on antimicrobial stewardship, not only because that's my expertise, but because I really am passionate about it, and I need to know that I'm doing everything I can to make a difference, and certainly professionally, but personally as well. I think pharmacists can have a massive impact, and it's not just in your job, like even just having a conversation with the school mums about whether or not you're going to get your child vaccinated for flu. You can change people's minds just by having that conversation. And I think it's important to think about the impact that you have, not just within your role as your job, but also within your personal life as well.
Yeah, absolutely. And what a good story to link between your kind of home life and work life, and having that kind of passion and that purpose behind what you do and that reason why you do things is so valuable. And
yeah, I think I annoy people actually. It's all I talk about. Oh, the GP is now known as that pharmacist that talks about antibiotics all the time. But you know what? I'm quite proud of that. If it sticks in their mind and it makes them think, then I'm happy.
I think it's great. I talk about podcasting a lot, so people probably get very annoyed with me because I'm always talking about how incredible it has been to start this journey, how much fun I've been having, how I found my passion. I found something that really gives me purpose as a pharmacist. And I've always thought of myself as a clinical pharmacist, and I've worked in lots of different roles, but pediatrics has become my thing. And now I'm doing something different, something a bit more unique, a bit unconventional, but I am absolutely loving it. And yes, I do shout loud and proud about it all the time because I enjoy it that much and I want to share it with the world. And I want to see more pharmacists also sharing their voice, sharing their thoughts, their expertise, because I'm so aware of how much of an impact that I'm making on a global scale. It's not just in my local hospital or with my local patients or, the people that I know and see face to face every single day. We're talking, 125 countries tuning into the podcast and learning more about the pharmacy as a career option. And even A-level students are finding me when they're making choices about their career in the future, and they come across my YouTube channel, and it helps them to make that decision as to whether or not they think it's going to be a good choice for them. So when you think about your why and you think about that purpose, it makes a massive difference to every single step or every single change that you make in the work that you do. So yeah, continue doing that. I love it. Be bold. I love that. So tell us a little bit about, I guess, becoming an independent prescriber. I'd love to hear how you've implemented that into your daily routine as a pharmacist and how it's different to being a non-prescriber when you're clinically screening and reviewing prescriptions. What kind of thought processes change? How does your mindset shift when you're managing patients? Maybe you can share some of that story with us.
Yeah, of course. So I became an independent prescriber when I moved to my antimicrobial stewardship role within my region. All 8As have a prescribing qualification. So when I then moved into an 8A post and I didn't have one, they kind of required me to do the qualification. And at the time, that really annoyed me because I thought I actually did a really good job as a pharmacist without being a prescriber. I didn't feel like I needed it. I had good relationships with my doctors on the wards and I could explain my reasonings and we came to a joint decision about changes that need to be made. But I did the course and really enjoyed it, actually. I found it incredibly rewarding. And, I said earlier on, I don't really like that sort of touching patients, that ickiness of the patients. But I found that I was actually not, it wasn't as bad as I thought it was going to be. The specialism that I chose meant that I didn't need to I did respiratory infections mainly, and because of my background, and there was a bit of sputum, but there wasn't too much sort of any other body parts, and not really too many feet, which would have been an issue for me. I found it really rewarding doing the course, and I'm one of these people who I like to achieve things. I like to have another qualification or a certificate to show that I've done something. So it felt quite rewarding from that perspective as well. It also gave me the opportunity to work with some of the consultants in my new hospital and get to know them and build a relationship with them, which was brilliant, and learn about how this new trust that I worked in kind of functioned and worked and linked in with primary care and spoke to the patients and that sort of thing. So again, valuable undertaking the course. I was surprised by how much I did use it. And I think one of the things that I realized is this assumption that I had that these decisions I had been making were a joint decision between me and a doctor were completely erroneous, really. If as an experienced clinical pharmacist, you turn around to your F1 on the ward and say, I think this needs changing. What do you think? Their renal function's not great, or we've got we've got cultures and sensitivities back that show that they're resistant to this antibiotic. Shall we change it? The F1 isn't able really to have an informed decision because they would feel like you're the expert in medicines and therefore they'll just do what you say. So I was assuming there was this shared decision making and that they picked up on some bits and I did other bits and we'd come to a joint decision. But actually what was probably happening is that they were just doing what I advised, or they might take it to their consultants and then the consultant would make the decision, which is obviously what they should do, I guess, in most situations. But by doing my independent prescribing, it gave me a lot more confidence in that I'd actually checked everything out before I made a recommendation on changing something. I have that responsibility. I wasn't kind of palming it off on someone else and saying, I think we should do this, but you make a decision. I was actually saying, I've checked everything that I think we need just from my clinical experience and my independent prescribing qualification knowledge. And I am happy to make this decision myself. And that was quite a big shift, actually, from how I'd been doing things before. And I mean, I guess it's just me personally, but I did find it really rewarding. It really improved my relationships with the ward team, actually, because the consultant could see that rather than just advising the juniors and then them making changes without them being involved, someone had looked at it properly, really thought about it. And quite often I'd have that conversation with the consultant direct rather than, I mean, obviously we wouldn't make a decision. We were working as a team on the patient, but I was able to have those conversations more in depth with the right person and understand the whole patient care journey and the plan that was in place, rather than just looking at a drug chart, saying something to the junior doctors and kind of expecting it to be done.
Yeah, totally.
Very long-winded way, sorry.
No, it's a really great answer, because there are a lot of young pharmacists who are tuning into these episodes, and a lot of them will be making decisions about whether or not they do the independent prescribing, what impact it's going to make, how they can use it in their role. So it's really valuable to hear this story. And I think with antimicrobial stewardship, every pharmacist does it, or they're expected to do it, whatever ward or clinic that they're in. It's really important, and it's a massive part of our job. And it has a lot of impact and a lot of value. But there is a massive mindset shift that you have to make when you are kind of signing or, putting pen to paper or signing something off electronically as a pharmacist who's screening something where a doctor's made a diagnosis and made a decision, to then being the person who chooses the right antibiotic, chooses the right route of administration, the right duration, when you have the power to switch from IV to oral, and what decisions or, I guess, information you have to gather to make that an informed decision for yourself and for the patient. And it can be quite scary. It's quite daunting. I mean, I am still working in a trust.
It should be scary.
Yeah, you're right. You're right. It shouldn't be an easy switch. And at the moment, I'm working at a trust that is still paper-based. So I have the power at the moment to use my purple pen and write all over the drug chart and stop things and change things. But it is not the same as when I stop something and completely rewrite it as a new prescription or a new duration or a new, frequency. When I then start writing that prescription, I think twice about what I'm doing, because it's still relatively new to me. And I'm also a little bit fearful of prescribing, because I am a little bit scared of putting that pen to paper, because it's such a big responsibility. And in a ward setting, it's quite hard, I think, because you don't have follow-up with the patient necessarily. I think if you're in a clinic setting, it seems like it might be a little bit easier, because like you might be responsible for seeing that patient 2 weeks from now to see what kind of progress that they make, whether or not they're adhering to the medication that you ask them, whether or not they are able to swallow it, or with children, are they having problems because of taste or crushing tablets or whatever it might be. When I worked in palliative care, it was more about medicines optimization for symptom management. So you would be working with the team or seeing that patient on a regular basis to get that feedback, to know and confirm that you've done the right thing. But I think it's quite scary when you're on a ward and you might only see that patient as a snapshot again, and then not necessarily have the opportunity to see what's happening to them at home and knowing whether or not you made the right decisions as well.
Yeah, I absolutely agree. But I do think that pharmacists are really totally capable and should be doing this role. I'm pleased that they're going to be expanding independent prescribing. I'm sure lots of people have concerns about the 2026 when all pharmacy graduates will come out being independent prescribers. Because for me, I guess I was an 8A before I even thought about it, and I had that wealth of experience behind me, and I feel that was really valuable for me. I had seen a lot of situations, I'd had conversations on a regular basis with consultants and done ward rounds. So I understood the thought processes behind some of the decision making, but it definitely made me a better clinical pharmacist. And it really did. I think it stopped me from putting other prescribers in a position that was an awkward one too. It wasn't fair for me to ask a junior doctor to make those changes on my behalf as a non-prescriber, because they didn't understand the reasonings and they didn't understand what I was talking about half the time. They just took my advice, and it felt like the right way to do it, to become an independent prescriber. But I wasn't happy about it at the time. And I have to say, I still value those skills. So I'm not patient facing anymore. I work for an ICB. We do sort of population health management, really. But having had those skills, I know what the decision making is like on the ground. And I do lots of training for GPs and non-medical prescribers, ANPs, on the target toolkit, the antibiotic target toolkit for primary care. But they wouldn't take what I say as being useful to them, because I'm just a pharmacist telling them what to do, unless I had that experience of being able to say, I know what this is like on the ground. I know how hard conversations about antibiotic prescribing can be in primary care. Like, it's a constant battle with every patient every day to say, I don't think you need them. I don't think you need them if they don't need them. But for me to have had that experience and be able to empathize with that and to think about the patient's needs as well as the prescriber's needs is really valuable still in my role, even though I'm not using it so much anymore. I'm certainly not prescribing.
But this is awesome, because you've got that residency, you've got that foundation, and you've learnt about all the different roles that pharmacists can have in a hospital setting, right? Whether you're on the ward, whether you're in a clinic, medicines information, dispensary, IT, finance, you've had the opportunity to see what lots of pharmacists do in different settings. And then you've transitioned into a specialist sort of ward-based role. And you've identified how much you like chronic diseases, you love antimicrobial stewardship and looking at infections and how we can treat patients and support them. And doing the independent prescribing course has just given you the opportunity to level up and take that one step forward. But now what's awesome is that you've obviously left a patient-facing role and you get to look at the wider picture as to what's happening across different sectors of healthcare and how we can link primary care and secondary care together and how we can improve patient care from that perspective. But you've also applied for the Chief Pharmaceutical Officer's fellowship program, which is really hard to get into. It's not an easy application process. There's a limited number of pharmacists who can get into this program. And I'd love to hear about your thought processes as to why you applied for it, and also why you chose UKHSA as the location to do your fellowship at.
Okay, yeah. So for those of you who don't know, the Chief Pharmaceutical Officer's Clinical Fellowship is a year-long program where you're meant to do it on secondment from your current role, and it's aimed at aspiring pharmacy leaders who don't have senior management experience, so 8As, 8Bs sort of level, to try and give them experience of working in a national organisation with a pharmacist who's a lead in their field. So you do the year working with them and you get experience of running projects and understanding more about how national policy is made. And they also combine that with some training and courses and education and support from the Faculty of Medicine's Leadership and Management. And that aspect is also done with the medical, the dental and the sustainability fellows. So you get this kind of NDT approach to formal training and a cohort of pharmacists, medics, dentists and MDT approach for the sustainability fellows, kind of all working together. I applied for it. As we've heard, I've got a lot of experience of sort of implementing national policy in secondary care and in primary care, but I had no experience of how these policies are brought about and how people work with government and with changing political landscapes and how they manage all of those aspects of it. So I was really interested in looking at that next level of practice. And, I said, we've got 2 kids, then Tom was ill. This is the first time in my career journey for a long time, since 14 years, my eldest is 14, that I've actually felt like it was the right time to focus much more on my career and what I wanted from it. Tom goes to secondary school next year. He's much better. He's not having regular follow-up. Will's already at secondary school. So it was the right time for me to apply for the fellowship. So when you apply, you put down options. So it's a bit like the Oriole in that you put your preferred choices. And my preferred choices were the organisations that I could work remotely for, which included UKHSA and NHS England. But there are fellows in other roles, so CPPE, RPF, CQC, so a range of organisations. I put 5, I think, out of the options, and then you get allocated. And I was just lucky. I was really lucky that I ended up at UKHSA, because it is my bread and butter. It's what I do every day. So I've kind of gone into it with a bit of a head start. Like I know what their acronyms mean, and I know about all the tools they've already developed for AMS. And it's been great. And I've only been doing it 2.5 months, and it's been the most amazing experience. I would definitely recommend. And in fact, I think the applications for the new cohort open in January. If people are interested, please do have a look at applying, because it's really good.
Yeah, I've interviewed a couple of fellows in the past as well. So I will link these in the show notes so that if people want to go back and listen to their experiences, it would be really useful. I absolutely love that you applied for this fellowship, because it just seems like the perfect next step when you're looking to stay in the same area of expertise, but then just build on it, and not just within your kind of local hospital or your local primary care setting or even the ICB, but you're really expanding on a national scale, and you're learning a lot of different skills as well in terms of leadership, policy development, and how we're changing things on a national scale rather than a local one. So good luck for the rest of that fellowship. Can't wait to see where things go for you at the end, and also how it's going to impact going back into your role and what sort of changes you might make or what sort of projects you might work on, knowing a lot more information from the fellowship. I just want to finish today's episode by actually asking you a little bit about sort of work-life balance, because from your story, you've obviously got 2 children, and I really like that you shared that now that both your sons are nearly in high school and one already in high school, that you feel like you're kind of able to not necessarily get your life back, but get your career back on track and really go like full forward into what you want to do and diving into that, because you've got the headspace for it as your children are older. Mine are 7 and 2, so I'm like in the depths of trying to do everything but struggling because they are still so needy, and not their fault at all. They have a lot of time. They need a lot of time from me. They require attention. They're not always doing things on their own for long periods of time like the older children do. So I feel like I'm really a little bit trapped between trying to push my career forward alongside being an amazing parent. And so I'd love to hear your story behind your parenting journey and how it's kind of linked with your work life. But also I understand that you've moved multiple times with your husband as well. And how has that impacted your career as well?
Yeah, so it has been an interesting journey. I think as pharmacists, we are incredibly lucky that we can work anywhere. You can get a job in a hospital or a GP practice or community pharmacy anywhere in the country. And when Dave and I first got together, I left my Sheffield, my first training post, to follow him. He went to do a PhD in pharmaceutics, actually. And then he got a job in a different place across the country 3 years later. So I moved and followed him. And that's just been the pattern, because he can't work anywhere and everywhere in the role that he does, but I can in mine. So it's been me following him around. That isn't how it is, but that is literally how it's been. is that I followed where his career has taken us, which is not near family. It has been hard. Like we don't have grandparents nearby. Our nearest family is 3 hours away, which is really difficult. And my family are 5 hours by car. So we've always had to balance. And I went part-time when we had our first child and haven't worked full-time since. And I think, although that was brilliant and I loved being with the kids and I do love being a mum, I am not very good at being with my kids all the time nonstop. I needed to keep my career and do something else as well. But I did the part-time because Dave needed his career. Like, I actually think that certain careers are worse for men if they do it part-time. They're not very good at being flexible around parenting for men. In some cases, it's easier for women to ask to go part-time than guys. So I went part-time and I did family life and I did all the running around after the kids and organising childcare and paying for childcare, even additional supports when I was ill and needed someone to look after the kids, we had to pay for additional nursery slots because we didn't have family nearby. You just didn't have that backup. And when we had the two of them, again, I went back part-time. And yeah, I guess it kind of feels a bit like you lose a bit of confidence in yourself. I've not worked full-time for 14 years now, and that's not the same experience as someone who's working full-time. And certainly when Tom got ill, the kids needed me. He needed me. And actually, my husband took 6 months off work and looked after Tom full time. I took 3 months off, but then went back to work. And Dave did the majority of the childcare. And then we got a nanny who is amazing. I could recommend it to anybody. She looked after the kids 3 days a week, before and after school, took them to school. When the days that I worked, she took them to school. She looked after Tom, took his temperature, made sure he got his chemo, kept an eye on him, made sure he ate the right things when I wasn't able to be right there, and takes him to club. And, she's been my godsend. But it's hard. It is really hard. And it has been really difficult. And we've just got to a point where we're relatively stable. We haven't moved around. We had 10 different addresses in 10 years between the time that I finished in Sheffield and the time that we moved to here. And we already had both kids by that point. So we'd moved house like 4 times with the children, which is difficult. We're still married. I don't know how. But one key point on that, make sure you get a removal company. Do not try and move dishwashers and washing machines yourself. It causes arguments. So we learned that early on. And I don't know, your kids are only little once and you don't want to miss out on that time. But I realised that I was sitting downstairs like with time off and they were sat on the computer or sat with their friends or sat on the Switch, and suddenly I had this time that they didn't need me constantly, which was brilliant. And yes, I miss them being little, but actually this stage is brilliant. It's so much fun. They're proper people and we can do fun holidays, and Tom's tall enough to go on the big rides and all of these things. When you have a family, you think about babies and little kids. You never think about having teenagers with their own opinions and own personalities and these wonderful people developing. And I love that aspect, but I need to be me again. I need to not just be mum. And this, I guess, doing the fellowship is partly to really try and rebuild my own confidence in my clinical skills and my ability, and that I can be a good pharmacist and not just a mum.
Thank you for sharing that. That's an awesome story. And it is tough.
I've been rambling, sorry.
No, it's not rambling at all, because it's a long journey. You've got 14 years to sum up in 2 minutes. I mean, it's not easy. And you have moved multiple times. We've got really similar pathways. We lived in seven locations in 7 years when we were living abroad. And then we moved back home, or we moved multiple times, like renting in different locations until we actually settled back into the UK. Because I lived in the UAE for 5 years and Sanjay, my husband, lived there for 10. So transitioning back to the UK, we kind of initially thought to live with parents and just see where we go, what jobs that we got, etc. And obviously we had one child back then. Getting her settled into nurseries and finding her even a space was hard. We were driving 45 minutes just to drop her off every day because there was nothing available when we moved back. And juggling all of that, moving house, moving countries, trying to keep on top of the career and be the best version of you, be the best parent that you can be, is not easy. And a lot of parents follow Pharmacist Diaries. There are so many pharmacists who are on social media that follow me because I am a parent who is trying my best. So I love asking these questions because we all go through different experiences, different stories, different challenges. Our obstacles are completely different. But at the end of the day, we just want to do what's best for us and the people around us as well. So I really appreciate your honesty today and your, genuine love for antimicrobial stewardship. This was an amazing episode and so much good information to be able to share with the world. So thank you so much for giving me this time today. And I'm really happy that we got to know each other too.
Yeah, it's been really lovely. Thank you so much, and nice to chat it through.